Everyone, welcome to this session on comprehensive ophthalmology. We have our first presenter whose paper is on comparison of lid reconstruction surgery with and without using 10/14F catheter as tissue expander. So please go ahead.
Good afternoon to all. Sorry.
Yeah, you're the presenting author.
Yeah,
Dr.
presenting
Anvesha
author.
Maitra.
Yeah. Dr. Kalpana Suresh. Yeah.
Go ahead.
Respected chairpersons and delegates, good afternoon to all. And my topic is on safety and efficacy of topical.
Just a moment.
Dr.
Yes?
Kalpana.
Sorry.
You are Anvesha.
I am Dr. Kalpana Suresh.
No, the first.
No, then the first.
The first paper is by Dr. Anvesha.
Anvesha Maitra. Why haven't you come, Anvesha?
Okay.
So,
my
1 second. She'll be talking on safety and efficacy of topical chloroquine as an adjunct to CMC 1% in mild, moderate dry eye disease. Go ahead, Kalpana.
Yeah. So my topic is on safety and efficacy of topical chloroquine along with CMC in mild to moderate dry eye disease. I have no financial interest to disclose. So as you all know, dry eye disease is a chronic pain syndrome affecting the quality of life adversely in patients. It's characterized by instability of a tear film with or without inflammation of the ocular surface and lacrimal glands, and accompanied by increased osmolality of the tear film and inflammation of the ocular surface. So various studies have revealed that inflammatory component to be the main causative factor in this disorder. Cytokine and receptor mediated inflammatory cascade and apoptosis have also been implicated in the pathogenesis of dry eye. Current therapies include tear supplementation, retention stimulation, along with anti-inflammatory agents. And chloroquine, as you all know, is a well-known anti-inflammatory drug used in the treatment of connective tissue disorders. And it has been evaluated on dry eye disease associated with inflammatory syndromes like Sjogren's, primary Sjogren's, and they concluded that there's a significant relief of symptoms of dry eye disease. And our aim is to evaluate the role of topical hydroxychloroquine, chloroquine as an adjunct to CMC 0.5% in the management of mild to moderate dry eye disease. It's a prospective pilot comparative study. Study population is 100. Both genders are included. Age is from 30 to 70 years and study duration is for 3 months. So 100 patients with symptoms of mild to moderate dry eye were included in this study. They were divided into 2 groups of 50 each. Group 1 received topical CMC 0.5% 3 times a day for 3 months. And group 2 in addition received chloroquine 0.03% twice a day for 3 months. The outcome measures were ocular surface disease index, breakup time, Schirmer's test, ocular surface staining. And they were followed up at the end of 1 month and 3 months. And the exclusion criteria include patients with systemic or local ocular diseases known to have caused dry eye, history of chronic contact lens wear, ocular surgeries in the past, and patients on local or systemic medications which is known to cause dry eye. And this was a dry eye disease questionnaire that was given to the patient. And the answers were recorded as how frequently these symptoms occur, if it is rare or sometimes or often or all the time. The presence of one or more symptoms often or all the time were taken as positive. An examination included visual acuity, condition of lids, meibomian glands, conjunctival surface and corneal surface, and post-segment evaluation. And dry eye disease test included breakup time, marginal tear strip evaluation, Schirmer's 1, staining with fluorescent and LG stain. Van Bisterval scoring system was used to assess the staining of ocular surface. And even asymptomatic patients with positive clinical signs were also considered to have dry eye. The follow-up was done at 1 and 3 months. And grading was done with Deuce dry eye severity grading system into mild, moderate, severe or very severe. Only mild to moderate cases were included in the study. And according to the symptoms, signs and the scoring system. Statistical analysis was used for chi-square and quantitative student t-test. And degree of improvement of parameters were assessed during repeated ANOVA. And between the 2 groups, it was compared using 2-way ANOVA. So coming to the treatment results, this is a trend line of improvement in different parameters in group 1 and group 2. That is the breakup time, Schirmer's, and lissamine green staining. So mean breakup time recorded in group 1 was better than in group 2 in all the follow-up visits. And degree of improvement of breakup time was 12 weeks after treatment from retreatment in 2 groups. But the rate of improvement in 2 groups were also similar. So implying that both the drugs were restoring breakup time to normal as equal in equal duration of time. Next, the marginal tear strip. Group 1 shows significant improvement, but it takes 8 to 12 weeks to improve. Whereas group 2 showed significant improvement in marginal tear strip in first 8 weeks, followed by a plateau, thus showing early onset of action and fast attainment of maximum respite. So this is the improvement in marginal tear strip. You can see with the pre-treatment, and this is group 1. It shows only at 8 weeks, but whereas in group 2, it shows early improvement. Also, the changes in Schimmer's value from the pre-treatment was found to be statistically significant, and the rate of improvement was much better, both in Schimmer's and fluorescent staining in group 2. Yeah. So conclusion is, both chloroquine and CMC are equally effective in treating dry eye, but the faster onset of action was observed with chloroquine group. And lissamine green was the only test showing chloroquine to be better than CMC. So differentiation can be due to different mechanism of action of CMC and chloroquine. Chloroquine is postulated to have anti-inflammatory and anti-apoptotic effect. So this might be the reason behind early improvement of ocular staining scores in chloroquine group. However, further studies at larger scale need to be done to corroborate, as this is a pilot study. These are my references, and thank you.
I want to know what is new about your study, because chloroquine has been in use for long. CMC has also been in use for long for treatment of dry eye. So what is the novelty of your paper?
So initially you can start with chloroquine.
Right away.
That is for a faster relief and improvement of all the parameters, and then it can be sustained with carboxymethyl cellulose, because finally the end result both attain the same quality of improvement.
But
because this reaches at 4 to 6 weeks, all the parameters seem to improve with chloroquine. It's faster than CMC. So you can start the treatment with chloroquine if you consider it as an inflammatory process, and sustain with CMC.
Because I think till now the reverse has been the...
But yeah, exactly, because your title of the talk is the chloroquine as an adjunct.
Yeah.
Adjunct.
So that means...
but we in group
CMC.
1 we use only CMC, but in group 2 with CMC, chloroquine was also added.
But then your title itself is misleading.
You add chloroquine to CMC, not CMC to chloroquine.
No,
chloroquine to CMC.
Yes, but...
Yes, but you are talking the reverse, just reverse. You are talking that you start
No,
with
this is a proposal. I have not done the study with chloroquine alone.
No, we understand that.
So I propose that chloroquine can be started initially to...
your topic should have been different, Kalpana.
No. My study was as an adjunct.
But
chloroquine as an adjunct.
What was different?
So because it was recovery was a little faster in chloroquine group, we propose another study has to be done, but that's not the conclusion of this study. This study shows a better improvement in chloroquine along with CMC group. So we can further...
As an adjunct,
As an adjunct.
Not starting chloroquine first.
No.
And then adding CMC.
No, that's not the study. So in future we can do a study to find out.
You are just now telling that you start with chloroquine and then...
Yeah, the study is not about...
Thank you very much.
Anyway, okay, fine. Thank you. The next one, please.
Excuse me.
Yes.
Which brand UV lube? What you have used? Chloroquine? What form you have used?
Chloroquine UV lube by drops.
UV lube, only one.
Only one.
Okay.
As far as I know, only one brand is available so far.
There are many brands available.
Hello.
0.03% UV lube.
It's okay.
Was it in Unim's form or
No, it's a
eye drops?
regular eye drops form. Regular eye drops, not unims.
Okay, fine. Thank you so much.
The next talk is by Dr. Anvesha Maitra. She'll be talking about the comparison of lid reconstruction surgery with and without using 10/14F catheter as tissue expander. Dr. Anvesha, yeah, please go ahead.
Good afternoon, everybody. The topic of my paper today is comparison of lead reconstruction surgery with and without using 10 or 14 French silicone Foley catheter as tissue expander. I have no conflicts of interest to disclose. Now, resection of tumors or following trauma or congenital anomalies can leave large eyelid defects and hence require reconstruction. Conventional tissue expanders are expensive and may not be a viable option for people in the developing world. We have introduced the 10 or the 14 French silicone catheter as an expander device. It is commercially available in the market and hospital settings. And in this procedure, there is temporary expansion of the skin and muscle complex. This expanded tissue is used in tensile rotation flap. The principle of this expander is that it is accomplished by placing a balloon-like expander underneath the skin, and there is graded expansion of the balloon with normal saline or balanced salt solution. Once a new skin has reached its desired size, the tissue expander is removed and the new skin is redistributed. This is a diagrammatic representation of the expander or the 10 French silicone Foley catheter. As we can see, it has been placed underneath the skin, and via the tube, balanced salt solution is injected into it, and it results in expansion of the skin overlying it. The aims or the objectives of my study was to evaluate and compare the surgical outcomes of eyelid reconstruction with and without 10 or 14 French silicone Foley catheter used as tissue expander in two groups of patients following excision of large malignant tumors. We have also evaluated the safety and efficacy of this expander and to evaluate the functional and cosmetic outcomes. Our prospective comparative interventional study over 18 months was conducted on two groups of 20 patients each, one group with the expander and the other without the expander. This study can also be extended to people with periocular scars or other eyelid scars, and exclusion criteria includes involvement of lymph nodes, distant metastasis, both lid involvement, corneal involvement, and orbital extension. We have evaluated the marginal reflex distance 1, left palpebral superioris action, and the palpebral fissure height preoperatively, and we have also done a preoperative confirmation of diagnosis by an FNAC. Now, this is what a silicone Foley catheter looks like. It is a 100% latex-free silicone catheter. It is a two-way catheter with a 10 French circumference. It can be inflated up to a maximum of 10 ml. And it is completely inert, and there is no buckling due to its bullet-shaped tip. This is the surgical procedure. Now, the active zone of the silicone Foley catheter is 1 centimeter beyond its tip. First, we have tested the silicone Foley catheter outside the human body. Then, after deflating it, we now try to insert it inside and underneath the skin. We have first marked this area of the skin we need to expand with the help of a surgical marker, and now we expand the skin. This way it is kept in situ for around 4 to 5 days, and on the 6th day we deflate the catheter and the new expanded skin is then redistributed. Now, again, in the postoperative period, we have examined the patients for their LPS action, MRD1 and PFH. Now, the incision length in both the groups have been compared. In the group where we have used the silicone Foley catheter as expander, the incision length is significantly less than in the group in which we have not used the silicone Foley catheter and we have just gone forward with a conventional tensile flap. As far as MRD1 is concerned, in both the groups, at the end of 6 months follow-up, the MRD1 is statistically insignificant, meaning that the result that we have obtained for with respect to MRD1 is comparable in both the groups at the end of 6 months. We have obtained similar results for palpebral fissure height and LPS action as well. Now, this is a diagram, this is a table showing that the MRD1 palpebral fissure height and LPS action at the end of 6 months for both the groups on follow-up is not significant, meaning that in both the groups, the results with respect to MRD1, PFH, and LPS action are comparable. This approach allows for tissue expansion temporarily, permitting the closure of eyelid defects, typically not possible with tensile flap reconstruction. This is not vision limiting because we do not close the lid. The flap can easily be rotated and there is minimal dragging force involved. The suture tension line is markedly reduced and thus wound dehiscence is absent. Incision line is also reduced, as we have already seen. There is decreased scar length and faster rehabilitation, making it much more acceptable. The effectiveness and the applicability of the tensile flap can be increased with the adjuvant use of this tissue expander. Our study highlights the successful use of a novel surgical approach for eyelid reconstruction using a 10 or 14 French Foley catheter expander combined with a tensile flap reconstruction. There is excellent functional and cosmetic outcome. These catheters are both cost-effective and readily available. The successful results of this novel utility make it a reasonable and cost-effective option also in developed countries as well. We believe this makes it an excellent tissue expander for use in the developing world, where access to other more expensive expanders are limited. This is a photograph of a patient. We can see that there's a lid mass and the silicone Foley catheter is in situ. After deflating it and reconstructing the lid with a tensile rotation flap, these are the post-operative pictures. These are some of my references. Thank you.
Good, that was nice. I had one question. Did you get any reaction to the Foley's catheter?
No, ma'am.
In any of your patients?
No, ma'am. Not a single case we had encountered any reaction.
You mentioned at the beginning that it is totally inert.
Yes, ma'am.
So that's why I thought I'd just confirm.
Was there any trichiasis post-op?
Post-op trichiasis, ma'am, we have only followed up the patient for 6 months. So as far as a 6-month follow-up was concerned, there was no trichiasis. We have not recorded any trichiasis in any post-op patients up to 6 months.
And when do you remove it ideally?
We remove it after we deflate the catheter on the 6th post-operative day, post-stage 1.
And suppose you did not use it, like in that case you showed, the last case that you showed. Can you just go back to your slides? Where first you inserted the catheter and then you did a tensile rotational flap.
Ma'am, this one? This?
It's
Okay,
not visible
sorry.
here. It's okay. I remember the picture. Suppose you had not done the Foley's catheter bit and just done a tensile flap. Would it have been equally effective?
Ma'am, actually for all the pictures that I've shown, I have actually inserted the Foley's catheter for all the pictures that I had shown of patients. So in patients where we did not insert the Foley catheter, we did encounter wound dehiscence in some patients in the second group, but with the first group where we have used the Foley catheter, there was none.
Okay, fine.
Thank you.
Any questions? Okay, thank you.
Thank you.
Sir, please announce the next.
So the next speaker is speaking on you read a book reader for visually impaired unread. A book reader for visually impaired. Now the presenting author is Dr. Pavitra Ravi Kumar. So your time starts now.
Okay. So good afternoon everyone. So my topic today is about YouRead, a book reader for visually impaired. So I would like to thank Dr. Sahitya ma'am for giving me this opportunity. So first we'll see the basic definition of low vision and what are the obstacles faced by the visually impaired persons. So and coming to the topic per se, where we talk about YouRead and its social impact and some of its limitations and why we can take it to the community. So according to the WHO, so a person with a best corrected visual acuity of less than 6/18 or any visual field restriction to less than 10 degree comes under the criteria for low vision. So in India, any person with a best corrected visual acuity of less than 10/100, 200 is considered to be legally blind, and he is able to receive government services and financial benefits. So despite having a huge human resources in the world, we have a sizable statistic of 62 million people who have visual impairment, which can be congenital or acquired. So some of the main obstacles what they face in day-to-day life. So the most important being inability to understand or use written communication because of the lack of literacy. So a large number of printed material which are available to us very easily are not being useful for persons with visual impairment. So either they have to depend on braille books, which can be very expensive and it's very rare to get also for all the content, and also audio books which are very limited, and even if they can get a volunteer who will only have a limited time to spare. So this is URead. So we'll be seeing a short video later in the part of presentation on how it works. So it's a innovative simple device for the visual impaired. So it enables them to listen to the printed matter using the naturally sounding voices. So one important advantage is it supports almost about 12 Indian languages, and it can read any A4 or legal size document or a bound book. So and also it has an option to back up all the books or documents whatever they need for later reference also. And important advantage is it doesn't require any internet connection, and it can function as a standalone device, and it does not require any companion devices like mobile phone or laptop to be plugged into the device. So this is a short video.
Place documents on the platform and press 8.
So as you can see, there's a platform where we can keep whatever document which needs to be read for the visually impaired persons. So as you can see, there are options on what speed we need to read. We can adjust the volume, we can pause it, and we can choose the language in which we can read.
Place next page on the platform and press 8.
AIOC2023 OM syllabus for moderate visual has 10 sessions, each of 1 hour duration and a spread for 10. Condense or enlarge them, depending on subject client's available visual acuity, innate abilities and the task/environment. Explain importance 006. OM syllabus for moderate vision impaired.
So coming to its social impact, it can be deployed in number of places which can actually help the visual impaired patients. One of them is in college libraries and teaching institutions, where they have to go and learn along with their sighted peers, but we don't have special equipments for them to access the library. And also in public libraries where braille books are not stacked, and we can create reading rooms even in their braille schools or blind schools, so that it can create an early reading habit for them. And also individually, when they have to go in for competitive exams or postgraduate exams, it will be of useful because they can access whatever content is already available. So some of its limitations include, one important is it cannot read handwritten notes, and it cannot interpret images, and still it cannot be able to cohesively read tables. So, and why we have to take this to the community, it makes them give an independent life with minimal assistance from others, and also gives financial independence because of their education and employment, and gives them a social inclusion. So they also deserve the same mainstream opportunities which their sighted peers get. So the goal is to give an inclusive or integrated education for persons with visual impairment to get special need education in the mainstream also. So these are my references, and thank you for the time.
What is the cost of this?
Now it is 25,000, ma'am.
And
So-
you're saying you want to take it mainstream, and how many people
No,
are
ma'am.
going to be
If
able to afford it?
no, if they get individually, it will be costly, ma'am. But if we can employ it in institutions like teaching institutions, so one URead is enough for all the persons who come for so many long years. So it main use will be in teaching institutions if they can get.
Actually, from your video, I could not exactly understand how it is working,
Okay.
because
Yeah.
it was not very.
No, ma'am. The audio was cut because I
because
couldn't
I couldn't
upload the original
follow-
video, ma'am.
I
So it
couldn't
was very
follow what
long.
was I mean, how the person is able to read,
Okay.
or is it going to talk to the person?
Yes, ma'am. It will come in. It will read line by line in English or
language
whatever
they decide.
language. Yeah, it will be. It will read line by line.
That didn't
Whatever
come
document
through-
we are.
That didn't come through in
Yeah.
the video.
Suppose it's there in the library or some institutions. The patient goes there, he reads. But how it is going to help the patient in day-to-day working? How it is?
Is it portable? That means, is it portable?
Yeah, it's portable, ma'am. It's portable. We have to plug into a switch, and it's portable only, sir.
Does it translate English to the 12 languages? Okay, read 12.
No, yes, sir. Whatever document we place it can read in whatever language you choose.
Okay.
Even
Pavitra,
if
there
it's-
are apps, reading apps,
Yeah.
camera-based images, iPhone apps. Is it superior to those?
No, ma'am. Actually, those apps, we require someone to actually operate it, like someone to press and give this. Just if someone can place the document itself, so it can read. And also most of them are available in bound books for them if we have to go for schools or colleges even. So most of them are not audio books or which can be operated as in laptops.
Actually,
So
there is an app called Audible,
yes, ma'am. Yes,
which
ma'am.
reads books to the person.
Yes, ma'am.
concerned.
Whichever is
But
available.
I don't think it reads documents, which is an
Yeah.
advantage that you read
Yes, ma'am.
has,
Yes,
which I
ma'am.
find. And the other advantage you've got, which you should emphasize on, is that it doesn't need a
Internet connection.
computer or
Yeah, computer or laptop
anything.
too. Yes, ma'am.
So
Yes, ma'am.
that will make it more accessible,
yes, more easy.
particularly in villages.
Yes, ma'am.
Thank you.
It is commercially available.
Yes, sir. Yes, sir. It's available, sir.
Where?
There is a stall here called Innovation Hub in the hangar also.
Okay.
So they have only come up with the idea. It's an NGO, ma'am.
Okay.
Yes.
Are they Chennai based or?
No, sir. They are not
Okay.
Chennai based.
Okay.
So
They're
I'm
not?
not sure about where they are.
What? I'm sorry, I didn't get what you asked. क्या पूछा आपने?
नहीं वो जो चेन्नई में some the instrument company, one who is manufacturing. I think somebody in Chennai also they were trying to.
Okay.
Thank you so much. Thank you.
Next, I'm going to invite is Dr. Atul S. Putalat. Yeah. He'll be speaking on FLUTO, that is filter light units for teleophthalmology, the future of smartphone filter light photography. Yeah. Atul.
Good afternoon, respected judges and my dear audience. I'll be talking about FLUTO, filter light units for teleophthalmology. As we know, fluorescein stain is put on cornea, and we usually take using a photo slit lamp. And switching on the cobalt blue light filter, we are able to take the cobalt blue light images of the patient with the cobalt blue light that is emitted. This is provided that you have a photo slit lamp. But what if you don't have a photo slit lamp? In cases like in emergency ocular trauma, where you don't have an access to a slit lamp or even a photo slit lamp, or in ICU and chronic bedridden patients, in infants for photo documentation, or in ICAMs where you don't have slit lamp at all. So what can you do? So I thought to myself, what if I could develop an attachment for a smartphone that is low cost? What if this attachment can be used by anyone, any health assistant, doctors and MLOPs alike? Any health assistant should be able to use it. What if it's portable, pocket sized and easy in handling? What if it provides good quality stain positive or negative images and is reproducible? With these points in mind, we opened up the old slit lamp in the instruments department and we studied the cobalt blue filter that's in the slit lamp in detail. So we've understood there are two ways to achieve this. One is using the inbuilt smartphone flash, or we can use an external light source. The aim is to emit blue light. So I can either convert the flashlight into a blue light or provide a new blue light as such. So with this working principle in mind, by keeping a blue filter in front of the flashlight, which will emit blue light, which will fluorescence, and you can see it as green lesion in the patient's eye. We developed our first model. This we had called as the cobalt blue light unit or sea blue. So these are the parts of the sea blue. And this was the first version developed around 1.5 years back. We photographed these images with the sea blue adapter, but then that was a bit cumbersome. It was a large unit. It did not fit all units. So we tried a few variants. We tried a sea blue clip. We tried a line light. We even tried a circular illumination setup. So but it was not universal. We wanted a universal design. So we went on to make a small, universal, cost-effective solution to this. So we developed this small patch that you see on the tip of my fingertips. It's called the blue patch, which was a truly universal design. So what is blue patch? It uses the same sea blue principle we discussed a while ago. It uses gum paper, so it is sticky. It's similar to a bindi strip that you can buy. So it comes as a strip. It's machine cut into precise circles. And it's a short video on how the blue patch is used. So you stain the patient's eye with sodium fluorescein strip, and you can use any smartphone. You don't need a high-end phone as long as it can capture. This is a 7-year-old model of Android phone. You can take a blue patch from the strip, stick it onto the flashlight of that phone, and just ensure that it is stuck properly and covering the flashlight. And then it is ready for your blue light photography. Now, after proper positioning, and you should use a dimly lit room or a dark room, which is preferred. And after correct focus, as you can see in the inset video image, the image of the patient can be captured. So we went on to a pilot testing of 34 patients with stain positive corneas. We collected user feedback, and also we gave the images captured to 2 expert graders to grade according to the criteria shown. So in the results, the user gave feedback that around out of 30 patients, people said it's very easy to use, and few others, as you see in the pie chart. In the expert grader analysis, where 1 and 2 is the best, 5 is the worst, most of them said 1 and 2. So they had good agreement with the, there was less artifacts, less blotchy appearance, diagnostic confidence was excellent, contrast was good, sharpness was good, and noise was less. Sorry. So after we developed the blue patch, we have now also developed glue, which is called the green light unit. We have just developed it this year, 2023, and we have already started testing it on patients to capture NVIs in the eye, or even using a 20D to capture RNFL defects if it's possible. The opportunities are many. So we use a red-free filter, which is attached onto the smartphone, as you see. And so this is a simple, inexpensive, very quick learning curve, and along with teleophthalmology, this promises development and quick relay through the internet, and it's also very accessible to all the people because it is a very handy thing, can be put in your pocket. And our vision is healthcare staff with minimal specialized training can remotely capture and transmit usable images to supplement and promote healthcare communication and efficiency. Thank you.
It's a very useful device.
This was, I think, in IGO last year, 2022.
Yes, ma'am. The first adapter I showed, I have published, ma'am. Yes, ma'am. So it's made of a gum sticky paper, sir, and we have tested it using spectrometers so that the correct wavelength that's needed is, and we are planning to go with make it commercial later on. Orolab is helping me with making the prototype final.
Yeah.
No, if it works well and if it is the price is very reasonable,
yes,
it will be a wonderful tool for teleophthalmology.
Yes, sir. We're planning at 50 to 100 rupee per strip, which will at least give you four blue patches.
Okay,
that's the aim for teleophthalmology.
So anything else?
Thank you.
Thank you, sir.
Okay, thank you. Our next speaker is Dr. Prasanna. No, I think Dr. Prasanna is going, and Dr. Anushri Bhatkar. Dr. Prasanna is going to present last.
Okay.
Anushri is going to talk on, is she there? Okay. Understanding vitamin D receptors and its impact on ocular surface disease. Please go ahead.
Good afternoon, everyone. So I'll start with my talk. There are a myriad of treatment options that are available for dry eye disease, and cross-linking remains the gold standard for keratoconus treatment and stabilization. But still, there are some patients who do not respond to the treatment, and some do respond to the treatment. So this necessitated the need to look beyond the existing treatment strategies. So this is the work that our team has done to understand the importance of vitamin D and the ocular surface, and we have established that vitamin D deficiency is associated with ocular surface inflammation. In this current publication, we have summarized the role of vitamin D in the eye. So it helps in dampening the inflammation and improved immunomodulation. It acts as it improves the corneal epithelial barrier function. It enhances wound healing and reduces pain and nociception. So the prevalence of vitamin D in India is noted to be more than 70%. But still, why do all vitamin D deficient patients do not develop dry eye disease or keratoconus? So for any disease to manifest, there are three factors that should come into play. One is the etiological factors of the disease, the genetic background, and the host response. So vitamin D basically affects the host response. That is how the cell is going to respond in a stress situation. So if the patient is only vitamin D deficient and the other factors are not strongly present, then the patient will likely develop a subclinical form of the disease. On the other hand, despite having a normal vitamin D level, some patients still develop dry eye disease or keratoconus. So this is important, that beneficial effects of vitamin D are carried out when the vitamin D binds to the vitamin D receptor. And that is why presence of adequate amount of vitamin D receptors is of paramount importance. So we can say that vitamin D receptors, if they are reduced in number in the ocular surface, that they would provide inadequate number of binding sites for the vitamin D, which could hamper its function. This brings us to our research question, that can vitamin D receptor be the key in dry eye disease pathophysiology? So we saw how the ocular surface cells are affected at the molecular level in dry eye disease. We took conjunctival epithelial cells using impression cytology from normal patients and from normals and from dry eye disease patients. We did a quantitative PCR to look at the inflammatory markers, and we did an immunofluorescence to measure the TONI-BP and vitamin D receptor expression. So TONI-BP is nothing but an osmolarity biomarker. Basically, it represents the osmolarity of the ocular surface. And we know from the definition of dry eye given by T. Foss Dusto that hyperosmolarity plays an important etiological role in dry eye. So what we saw was that in the dry eye disease patients, there was increased expression of TONI-BP, and there was a decreased expression of vitamin D receptors in the epithelial cells. So we could say that the hyperosmotic environment was degrading the vitamin D receptors. The second question was, how does vitamin D receptor play a role in keratoconus? So we collected epithelium from 30 keratoconus patients and from 10 controls undergoing PRK, and we collected the epithelium from the cone and the periphery. We stored it at -80 degrees in our biorepository, and then we did a Western blot to look at the protein expression and a quantitative PCR to look at the gene expression. We observed that the vitamin D receptor expression was lower in the cone area as compared to the periphery in the keratoconus epithelium, and the vitamin D receptor expression was lower in higher grades of KC. We know that LOX or lysyl oxidase enzyme is an endogenous crosslinker, and the expression is reduced in keratoconus patients. So we induced keratoconus by creating an oxidative stress in cultured epithelial cells, and again we observed that there were low levels of vitamin D receptors in these patients, and significantly low levels of LOX and increased expression of MMP9. We treated these epithelial cells with vitamin D, and we observed that there was an increase in the LOX expression, increase in the the vitamin D receptor expression, and reduction in the MMP9 expression. In a recent publication, we have published our treatment algorithm that we follow in severe deficiency, that is less than 10 nanogram per ml. We give an intramuscular injection followed by oral treatment, and in moderate deficiency and insufficiency, we give an oral supplementation. So we studied the effect of this vitamin D treatment on the ocular surface. So we collected epithelial cells from keratoconus patients who were vitamin D deficient using impression cytology, and we looked at the gene expression again of LOX, COL1A1 and COL4A1 before and after systemic vitamin D supplementation as per our algorithm. So we observed that the systemic vitamin D treatment enhances the expression of LOX and COL1A1 and COL4A1, and this could improve the structural integrity of the cornea. So this is some recent work that we did, and it could be the way forward. So we in dry eye disease patients, so we induced hyperosmotic stress in cultured epithelial cells, and we treated it with genistein and calcitriol, and again we looked at the TONI-BP and the vitamin D receptor expression using Western blotting. So genistein is nothing but an CFTR activator, so it basically regulates the chloride transport inside the cells. So it helps to improve the cell stability, and it keeps a good ocular surface milieu basically. So what we saw was genistein and calcitriol blocked the hyperosmotic stress-induced VDR vitamin D receptor degradation that we saw, and it improved the survival of vitamin D receptors in the epithelial cells. in this in vitro study. So to summarize, what was known is that vitamin D is a natural endogenous anti-inflammatory regulator, and vitamin D deficiency is associated with ocular surface inflammation, and it may affect the surgical outcomes. What our study added was that the vitamin D treatment itself induces vitamin D receptor expression on the ocular surface. The vitamin D and vitamin D receptors are reduced in dry eye disease and keratoconus patients. The hyperosmotic stress in ocular surface inflammation degrades the vitamin D receptors, and genistein and calcitriol may rescue this degradation. Vitamin D supplementation also increases the LOX and collagen, and it could stabilize KC. Thank you.
Wind up. Oh, you're done. Okay. Good study.
Thank you.
Is there any direct relation with keratoconus, vitamin D deficiency?
So, sir, we have seen that it causes ocular surface inflammation. So that is why there is a raised MMP9 in the ocular surface, which could cause an extracellular matrix degradation, and then which has a role in keratoconus.
In routine practice, see the vitamin D deficiency.
So we do look at vitamin D, and we supplement them according to the treatment protocol. So that is what we follow.
This morning I heard a paper either from your institute or from Arvind, where raised IgE was more responsible or more correlated to development of keratoconus than vitamin D deficiency.
So this is in addition to the existing factors, so that we are not saying that the routine treatment should be given, but apart from that, a vitamin D supplementation would help.
Good afternoon, dear audience and honorable chair and judges. I'll be talking about tumor DNA sampling from aqueous humor in retinoblastoma. I thank my co-authors. I don't have any financial interest, and this study was funded by the Institute Research Grant. So basically, retinoblastoma is initiated by a...
Take up the mic a bit. Voice is not coming.
Yeah. Is it better now?
Yeah, that's
yes. All right. So retinoblastoma is initiated by a biallelic loss of RB1 gene. There's no pointer here, but if you can see on both the alleles of the gene, when there is a loss of RB1 gene, that is when you tend to get a retinoblastoma. Now, germline mutations are carried in blood on one of the alleles, and we can study these mutations from the blood. But somatic mutations which are acquired later on in life can be assessed only from tumor tissue, and all of us know that tumor biopsy is contraindicated in intraocular retinoblastoma, and that is why role of genetics till today has been explored mainly in predicting survival prognosis from tumor tissue that is taken from enucleated eyes. Its role in predicting globe salvage remains largely unexplored. Yes, so recent reports show that it is possible to isolate cell-free DNA from aqueous humor of eyes that harbor retinoblastoma. And most of these studies are basically from a single institution. So we decided to conduct this study to evaluate if we could reproduce the same in our set of patients, and if we could do a RB1 gene exome sequencing from the DNA harvested from the aqueous humor. So what is cell-free DNA? Basically, cell-free DNA refers to the DNA fragments that are released when the cells undergo apoptosis, necrosis, or some death during the division of the cells. And so this is basically present in the body fluids. And so the DNA, the cell-free DNA, is also derived from the tumor cells when you have a tumor. And often this DNA that is derived from the tumor overrides the normal clearance, which is done by the macrophages. So macrophages will take away the cell-free DNA, but when you have a tumor, the production of cell-free DNA is much more than that can be cleared by the macrophages. And this gives rise to this hypothesis that the aqueous humor of an eye which has retinoblastoma may contain cell-free DNA that has been derived from this tumor right here. And so if we can sample this aqueous humor and then isolate the cell-free DNA, we may be able to access the genetic mutations which which have been acquired in this tumor in the lifetime of the patient. So this was a prospective observational study. Ethical clearance was taken from the institute. And basically, we did this on eyes with advanced intraocular retinoblastoma that were planned for enucleation, and also in eyes where we were trying to salvage the eyes with intravitreal chemotherapy. We excluded the cases where anterior segment was involved by the tumor or there was a previous history of chemotherapy. How did we collect aqueous humor? It was through a clear corneal paracentesis using a 32 gauge needle and a tuberculin syringe, and 0.1 ml of aqueous humor was taken and stored at minus 40 degrees C till further processing was done. So basically this is the workflow of the whole genome exome sequencing that is done. This is all more pathology related, but basically we use the Quagen circulating nucleic acid kit for isolating the cell-free DNA, and thereafter the quality and the quantity of DNA was checked on the nanodrop spectrophotometer. The quality and purity was further improved by using 1% agarose gel. Now this cell-free DNA, basically a library preparation is done. So basically the isolated cell-free DNA is first purified, then it is enriched, and then we go on and do the sequencing. Basically what is done is that the sequencing that is read is compared to a reference genome, which was GRCH38 that was used in our study. And after that, once you've identified the sequences, you look for the variants and decide whether they are pathogenic or not. So Varimat pipeline was used for the annotation. Now we did this in 26 eyes of 25 patients. They were mainly male patients with bilaterality of disease in 7 patients. 20 of the eyes underwent enucleation. In 6 eyes, we were giving intravitreal chemotherapy, so they were undergoing salvage treatment. And we were able to get cell-free DNA in all the cases. And this was cell-free DNA because by the characteristic of cell-free DNA is that it peaks at 140 to 160 base pair. That's the size of the base pairs that you get for these exomes. Now, in 25 eyes, the mean concentration that we found for the cell-free DNA was 23.65. It was higher for patients that underwent enucleation compared to the ones where we were doing globe salvage treatment. So we were giving intravitreal chemotherapy. This is the data sheet showing all the cases that we did. Now, essentially, we could do targeted exome sequencing only in 4 samples of aqueous and 2 tumor tissues, basically because of financial constraints. And this is what we found. So in 2 patients where we did both tumor tissue and aqueous, we did find some correlation, or we find similar pathogenic nonsense. Can I continue? This is just the last slide.
Yes.
So yes, so here in aqueous humor and tumor tissue, the same mutation was found, which was nonsense and pathogenic. In the other case, we did find RB1 gene mutations, but they were not similar for tumor tissue and aqueous humor. But we were able to find mutations in all aqueous humor samples, and all of them were pathogenic for retinoblastoma. So I'll skip the discussion and I'll just go on to what finally I want to say here is that our study validates the previous reports that aqueous humor may be used as a source of tumor-derived cell-free DNA. This is a preliminary study and the first one from India which has reproduced the same results that have been done in the West, and we need to do it more to be able to reproduce in rest of the centers. But it's a big step forward in prognostication for globe salvage and not just survival in these patients. Thank you. Thank you.
Good. It's more of a laboratory-based thing.
Yes, ma'am.
And what is its clinical implication?
It has a huge clinical implication, ma'am, in the sense that now intravitreal chemotherapy is being used extensively in advanced intraocular retinoblastoma for globe salvage. So if we have diffuse vitreous seeds, we give intravitreal chemotherapy, which was not being done a decade ago. So we are anyways putting the needle inside. So what we do is, before we do intravitreal chemotherapy, the aqueous sample is taken to reduce the intraocular pressure. Paracentesis, as it is a part of the procedure in many centers. So we had the aqueous sample. Now this sample can actually be used to prognosticate whether you will be able to salvage that eye or not based on the mutations you identify.
What is the cost incurred for this?
Yeah, it is very costly actually. So it is around 30,000 for a single sample exome sequencing. That's why we could do it only in 4 patients. But we now have a collaborative project on the same, and we want to do more work on this.
So 4 patients is too little.
Yes. It is definitely costly, ma'am, but if it finds its way, it will have a huge implication on the globe salvage.
Let's see.
Okay. Thank you.
Sir, next को बुलाइए.
Monday को आया. Which one?
Next speaker.
The next topic is quality of vision in colorblind. Analysis by simultaneous stimulation. Nilanjan Chaudhary.
Is it there?
Nilanjan is not there.
No. So next.
Okay, then we switch over to the next.
Next, Jitendra Nenumal Jathani. He speaks on effect of DIMS lenses in halting the progression of myopia, not responding to LCA eye drops.
So this is just to tell that I am a key member in SLR Private Limited for Stellist, which is not DIMS. So why myopia progresses? There has been a load of literature in last, I think, 1 decade. There have been a lot of work on why exactly myopia increases in children. So one of the key factors is that near work causes peripheral hyperopic defocus, and another key work is on the altered dopamine release. My talk is on both, so I will be combining the two things. At this point of time, we all know that low concentration atropine is at the basis of treating myopic progression. One of the landmark studies was ATOM-1, which was published in 2006. And since then, we know that it works for myopic patients, myopic children for progression. But it is a harsh reality that almost 20 to 50%, depending on which literature we read, there are a number of patients who do not respond to low concentration atropine. And one of the possibilities is to increase the concentration. And second possibility is to give a DIMS lens or a Stellist lens. Now with this background, we did a study to find out the effect of myosmart lenses or DIMS lenses, as they call it, as an addition to low concentration atropine eye drops on myopic progression in children who are not responding to 0.01% eye drops. We selected 10 children. This was a non-randomized single arm interventional study. The glass power was increasing more than 0.5 diopter per year, and the primary endpoint was to see the progression at the end of 1 year. So at the end of 1 year, the mean spherical equivalent was 3.9 diopters. Pre-atropine progression, before starting the atropine, was minus 0.76 diopter every year, which reduced to 0.68 post-atropine. So atropine was working, but not as much as we would like to. And then post-DIMS, the mean progression was 0.39 in total 10 patients. And if there were 2 patients who actually did not respond to DIMS, they were still increasing. And so the patients who responded, the response was quite good. So we all know that low concentration eye drops are safe and very efficacious at this point of time, but there are good number of patients who do not respond to low concentration atropine. The dose can be increased, or we can alternatively prescribe these peripheral defocus lenses. What is peripheral defocus lenses and how do they work? So DIMS is defocus incorporated multiple segments. I showed the picture. There were multiple segments in that were plus 3.5 diopter, and these defocus segments are incorporated in the glass, leaving central 9 millimeter clear of anything. This all theory has started because of the publication by Earl Smith, which was published in 2009, saying that it is peripheral retina which is responsible for growth of the eye and not central retina. He has got wonderful article. He has followed up it in 2010, 2013, multiple articles on this. So how does DIMS work? This is the picture. What it does is those peripheral 3.5 diopter lenslets or defocus incorporated segments, they make a myopic defocus. This is the myopic defocus, and that is how they halt the progression of axial length. There have been articles starting from 2020, and then there was a recent final report of 6-year follow-up where they had multiple groups in patients only on DIMS with single vision, patients who wore single vision for 3.5 years and then DIMS, and then there were only single vision patients. So what the conclusion was that DIMS glasses do reduce the myopic progression and there is no rebound effect. In our particular work, we tried to show that we added this DIMS lens. So it was not a primary DIMS lens study. It was used as an adjunct. I mean, it was added to low concentration atropine in patients who are not responding. So this is clearly different from what has been studied across the globe. We did the peripheral refraction of our patients, and we found that they indeed had some hyperopia in the periphery. So basically, peripheral refraction would be 22 degrees temporal and 22 degrees on the nasal side. The refraction differs, and our study is unique that we prescribed these glasses in patients who were not responding to atropine. They were in conjunction with low concentration atropine. So the point is, it's opened new possibilities for patients who are not responding. Despite giving atropine, if they are still progressing, we can prescribe DIMS lenses, and that is the conclusion. Thank you so much.
I have one question, Jitendra.
Yes, ma'am.
When they did not respond to 0.01%, did you increase the concentration?
Yeah, so when they did not respond means they responded, but not as much as we would like them to. So we increased the concentration, as you said. We increased it to twice a day.
Oh, you mean you increase the dosage?
Yeah, not the concentration.
Not the concentration.
Because it is not currently available. So we will have to formulate it.
Okay.
But they did not respond to 0.01%.
And you added DIMS?
We added DIMS. We did not withdraw them from atropine.
Okay.
Sure, your number of cases are very less, 10. In other studies, there is a more number. What number?
So this is one of the first studies which we are talking about DIMS. DIMS lens costs around 15,000 per pair. So it's pretty expensive. So the number is low, and this is one of the first works in India. It was launched 2 years back. So because myopia, you have to follow them up for a very long time, and we wanted to do it. Honestly speaking, this is not our first line of treatment. We treat them with atropine because obviously we are in a cost sensitive country. So we treat them with atropine, and that is the reason we do not have any patient on primary usage of DIMS to compare. So these are all patients where atropine did not give a measurable response or as good response as we would expect. We added the glass to them.
Sir, in the OPD, can we make out the difference between this lens and the other lens?
Yeah, you can make out. I can show you the lens. I mean, this is a free paper session, so but I have the lens. I can show you the lens. You can make out. You can put a torch, and you can actually see those segments. Yeah, it's.
And just one observation I would like to make, because I was in the US recently, and there one of my son's friend's daughters was on on low concentration atropine, and suddenly her pupils dilated, and you know how it works in the US.
Yeah, they will become very scary.
They went to ER, and the physician didn't have a clue
what is wrong
of what is happening. And as soon as someone mentioned it to me, I said she must be on some drops.
Yes.
She has to be on some drops. And then in the evening they brought her to show me, and the first question I asked was, "What are you using?" And she was using higher concentration.
That happens, madam. We prescribed 0.01%. Patient thought that this is 232 rupees. I will get atropine from somewhere else. Got atropine 1%. Called up at midnight that you have given the drop, doctor, and the patient is not able to see. I was putting 1%.
Jitendra, what was the side effect of doubling the dose? Means twice daily.
There was no side effect.
It didn't work.
It didn't work, but there was no side effect.
Side effect means the patient's losing accommodation problem or...
No, sir. There was no side effect. So actually I have a couple of papers on doubling the dose. So there are, 30% of the patients would respond to doubling the dose, and 70% would still not respond to doubling the frequency.
And another point I would like to highlight here is, because since you are talking about low concentration atropine, is that many of our own ophthalmologist colleagues who are not into pediatric ophthalmology are not prescribing atropine, because some of my patients have told me ki I went to someone else after you told me, and they didn't say that you should put atropine.
Glass is there, madam. If you want to see the glass, they can see the glass.
We have to accept new things.
Yeah, actually, once we are after an age, it becomes difficult to really trust the medical wraps, because, like DIMS, also it's a market-driven technology.
Yeah.
The cost is 15,000. We understand that we have to accept it, but we do not have to follow it. That we start primarily on DIMS and not give due credit to cheaper drugs or cheaper things.
Right. Thank you so much.
Okay, ma'am. Thank you.
The next speaker,
Dr. Burgohen. You are there? Yeah.
no, I think this is, you are what's your name? Okay, okay.
Last one.
Are you're a AIOS member? Okay. Go ahead, please. His topic is Ophthalmological Society of Assam, Automated Machine Learning for Optical OCT, Image Classification.
Yours is the best of state paper?
Yes, sir.
Oh, best state paper.
Best free paper presented at the state of Assam.
From Assam.
So that is included in the.
You don't have to, you have to evaluate. Yes. You have to evaluate, because then it goes into the semi-finals. Go ahead, please, start.
Good evening, everyone. My topic is automated machine learning for optical coherence tomography image classification. I have no financial disclosures. So in every machine learning model, it undergoes a series of steps which involve a lot of coding. So what automated machine learning does is it automates some of these steps, such as the algorithm selection, the pre-processing methods, and the hyperparameter optimization. It also uses something known as the pre-trained models, that is, models that have been already trained on some other data, which you can repurpose to use for your own models, as we have done in our case. So as we know, India is a developing country with a scarcity of qualified ophthalmologists, more so in the peripheries. The ratio in urban India for ophthalmologists to population is 1:25,000, and in peripheries it is close to 1:2 lakhs. So incorporating such machine learning models for image classification can help us in filling this void and to facilitate efficient referrals. OCT images have been proven to be excellent biomarkers of retinal disease activity, and these images can be used to train such models. The objective of our study was to create and train an automated machine learning model for OCT image classification for common diseases. We used a publicly available dataset which comprised of source labels of age-related macular degeneration, central serous retinopathy, macular hole, diabetic retinopathy, and normal OCT scans. The automated machine learning platforms that we used were from Google, Apple, and Clarify. So first, coming to the Google model, it showed an average precision or accuracy of 0.97. It showed a precision of 98.21% and a recall of 98.21%. Coming to the individual labels, it showed very good precision for AMD, CSR, and diabetic retinopathy, and it showed good recall for macular hole and normal images. Here are a few examples of what the machine had predicted correctly in case of diabetic retinopathy, as you can see in the upper pictures. Then coming to the second model, which was of Clarify, it showed average accuracy of 0.95, and it showed a precision of 72% and a recall of 57%. Here we can see the individual labels and the recall precision graph and the ROC curve. So here basically we can see that for the normal labels it had done well, as well as for the macular hole scans. Where it had done worse is for age-related macular degeneration scans. The third model was from Apple AutoML, and this had an accuracy of 64%. With a highest precision of 100% and a highest recall of 80%. Here are a few examples in which the model had predicted correctly for diabetic retinopathy, for CSCR, AMD, and macular hole. So coming to the discussion, amongst clinicians, we have a very limited knowledge of machine learning. So what AutoML does, it automates the process and it requires no code. So it democratizes machine learning and everyone can start doing their research. And what it does with the pre-trained models is that it trains a model faster than the traditional methods. So our model had performed well with the given data set, and these models trained with Google and Clarify were somewhat superior to the one trained with Apple, and this could be because Google and Clarify, they had cloud, they run on the cloud, whereas Apple, it runs locally in our machine. These results demonstrate that competent machine learning models can be developed with no experience in coding and in a relatively shorter time period with the help of automated machine learning. OCT images have been proven to be a very reliable marker, and we can use these images for training these models. And we can use OCT images because there has been a very improved growth in its technology with the introduction of portable OCT machines as well as handheld OCT devices. In a few cases where they have also reported where patients have been using it at home by themselves. Although it's a very good technology, there are still a few limitations that they still require careful dataset curation, class balancing, representative patient level splits, external validation, and continued monitoring to detect model deterioration. In our study, we had used a small data set, so with larger data sets, the results might vary. Also, we had trained only as one type of a model, so with different models, there might be different results. Also, there is something known as black boxing, in which we do not know how the machine has come to interpret the results. So to conclude, code-free platforms allow clinicians to develop machine learning models without the need to learn coding. And models trained with AutoML are equally competent in comparison to custom machine learning models. And automated machine learning models can be trained and deployed for OCT image classification in telemedicine for disease screening and efficient referrals. Thank you.
Very good. That was an excellent paper. Any questions from the audience? Actually, you cannot. Anyway, I think that's good.
Thank you.
Do we have the person who was not there earlier, Dr. Prasanna? You're there? Okay, please come. So his topic is 3D digital puzzle assembly for amplified learning, a comprehensive and competitive self-learning kit. Please go ahead.
Yes, ma'am. Thank you for the opportunity. So I'm going to go into basic sciences and how we use 3D printing for basic science anatomy pedagogy for self-learning, especially by the tactile touch. So theoretically, if we see a framework today, there are so much theory that has been discussed, especially if you see the complex structures that we don't dissect, like the cavernous sinus or the circle of Willis or even the eyeball for the matter. We never get to dissect these structures. And when you refer textbooks, there are different textbooks showing different projections of the same anatomy, and for a neophyte, it tends to get slightly disturbing or confusing as to what the real anatomical structures are. So that was the thought or the cognitive statement with which we wanted to approach this. And you can see again, if you browse circle of Willis or even eye parts of the eye for that matter, so there is not a single proper way or proper representation in two-dimensional learning. So can't we use 3D printing, which is very commonly done in ophthalmology, which is one that took ophthalmic fraternity by storm, to create simple basic science anatomical structures to make sure that learning is more cognitive. So this is the final 3D model that I have printed, which I'll be showing along with the circle of Willis that I am having in my hand, and as well as the eyeball model. So the concept was, just like an engineer, can we have the models printed for touch, feel, as well as to know where the structures are. So I got this idea from the toys and puzzles that the children used to play, like they assemble structures and they learn for a cognitive learning. So this is how we went ahead and we started with the anatomy book, the Cunningham's, the Chaurasia, and we used a Maya LT software to create this 3D anatomy, because a lot of reading had to be done to get the angulations right, and Cura software was used to print the models. So because especially when we print a thin model, it is very difficult to print it. So this is a video where you can see that the circle of Willis and the cavernous sinuses, as I told, which are non-dissectable structures, were actually reconstructed in three dimensions, and a simple basic science structure was actually printed for the love of learning and to make sure that the learning is being more facilitated in a much cognitive way rather than more textbook related or in a more mugged up fashion. So we did print these three structures related to ophthalmology, as you can see here. So these structures are also printed in with real-time fundus images. So you can see Fab Excel printer and Fab X Plus printer was used depending on the structure size. We used polylactic acid was the materials that was used for printing, which is biodegradable. And I have one model in my hand. At the end I'll show the other models as well. This is a circle of Willis. After the printing, it comes in unicolor. We'll have to just make sure we spray it and make it more redder in color depending on the structures that we want to have elicitation. So this is the first circle of Willis 3D model, according to my knowledge, that was actually printed, because 3D printing was being used for so many things. But when we changed our shift towards basic sciences, there were many things that were not explored. And also, like a puzzle, you can assemble it, learn it, so that you'll know, don't need to mug up the anatomy. Even the eyeball models also, we can see that the sclera, the choroid, the retina, the anterior chamber angle, we have used as much as reality as possible. The anterior chamber angle, for the retina, we have used true confocal fundus images. And this is the point. Can we really dissect these structures and learn it? And this was also validated, the 3D models. And you can see that, as I told about the coloring, every colors will have different adequate supports and so on. We can customize it every way. So every data of the patient, flecked retina with autofluorescence, infrared, any case that you have, retinal diabetic retinopathy, a fibrovascular band, and so on, everything can have their own case sheets, retinitis pigmentosa. I'll just show you. And we did put it into the population, that is the first year postgraduates. We did add a roadshow. We showed them these models. We took classes for them to know their feedback, and you can see that 97 users were divided into two categories. The satisfaction levels were analyzed with a pair t-test. Of course, when three-dimensionally, when they held a puzzle, the levels were much bigger. And it's not that without this, they were not very satisfied. They were satisfied to 89.44%. But the p-value was quite significant, and it really made a difference, especially for a first-year postgraduate neophyte or even for an undergraduate. So we are open these models in our website for open access so that anybody can download this. Can I have the cavernous sinus? Yeah, so this is the cost logistics of it. We have made it very economical. So this is a cavernous sinus model that I am holding in my hand. So this is like a puzzle. So we just don't need to mug up structures. And you can see the circle of Willis model is 200 rupees. The cavernous sinus is 200. The eyeball is 1000 rupees. Eyeball. And it took 10 hours to print the circle of Willis, 5 hours for the CVS model, and 30 hours to print the eyeball model. So this was the prototype model of circle of Willis, where we did not get the angulations correct. So we went ahead, and then this is the second model where we were able to get the angulations much better. And this is all cost effective because it's very fragile and it tends to break. But we have made sure we conquer this. So this is and we have also made sure we are also printing the anterior chamber angle structures and so on. So this is puzzle making, which is a very simple idea. The children do it with their toys. We just took this idea, and now currently we are working on validating a model which is more complex, where we can add all in one: the circle of Willis, cavernous sinus, the brainstem, the cerebrum, cerebellum, and so on. And so this, my dear friends, I feel will be the future of 3D pedagogy, because it may even benefit the undergraduate students as well, so that there is no cognitive blind spot. There doesn't need to be any mugging up there. And even the 3D eyeball model that we have printed, you can see that different structures have been printed in different diameters, so that they can easily be inserted. The lens is different. And inside the retina, we have used thermopolyurethane material. So if you see in the retina alone, so any structures that you can put inside this retina, you can have any picture, and this material is not not plastic, whereas this is more squeezable. So this can be used even for laser training and whatnot. So any fundus images can be added onto it. Thank you for your attention.
This
Very
was
good.
presented in the midterm conference and
Yes,
you got a
ma'am.
prize also.
Yeah, I was awarded the prize. I did mail them regarding that whether I should present it here again because I won the best paper in midterm. But since this is a more competitive session, they told me to present. Despite me winning the midterm, they told me to present here also.
Very good.
Yeah, because there was not a Rangacharya session or anything there, so they told me to present here. Yeah.
I loved the idea. I think it's excellent.
It's a wonderful idea. Yeah,
It's a
exactly.
beautiful idea. It can revolutionize how we teach undergraduates and postgraduates.
Yes, ma'am.
both. And as all of you know, nowadays we have a lack of human bodies,
Yes, ma'am.
especially for undergraduates. There is a severe lack
Yes, ma'am.
of. So this can, make up for that
Yes, ma'am.
lack.
Yeah, three undetectable structures. Like we wanted to focus more on neuro-ophthalmic anatomy.
I get it.
Yeah, ma'am. So we are making different prototypes.
It's beautiful. I think it's a very intelligent idea.
Thank you, ma'am. Thank you, ma'am.
This last speaker, Niranjan Chaudhary,
I think he's not there.
He's absent.
He's absent, na? So we'll mark him absent now.
Yeah.
Ma'am, shall we mark him absent? Okay. So we come to the end of this session. I think it's been a very fruitful session. I have learned a lot of new things from so many of the speakers. And as I always tell people that if you go to any conference and you pick up even a small nugget of knowledge, the conference has been worth it. And I think that's what I'm taking home with me today. One should always be open to learning. And I've learned a lot from you people today. Thank you so much. And thank you, the audience, for being there. Can we have a photo with all the presenters? We'd like that. Chaliye, sir.